Okay, so good afternoon and good evening, everyone. Good morning to some, I guess, wherever you are. Could someone just from outside the teaching group just put in the chat that they can hear and see me okay, so that we've got, make sure the audience is working well? Yes, thank you, Miriam. That's great. Okay, so apologies for that delay. There seemed to be an issue connecting to this platform via Edge, and we've used Chrome instead. So that's something we've all learned for future speakers in particular. So thank you very much for your patience. Today gives me great pleasure to welcome back from last week Dr. Noreen Akhtar, who is a consultant cytopathologist and also does head and neck pathology. She's a colleague of mine at Manchester University Hospitals in the United Kingdom. I'm presently in London, sitting in a conference centre on the edge of the Edgware Road, which is not the prettiest part of London. And so I'm very grateful to be able to have Noreen talking to us about cytology. We don't get a lot of cytology sessions. It's very a precious group of people in high demand, so we're very grateful for her teaching. So without further ado, I'll pass over to Noreen. Eva will be in the background to look after admins, and I'll stay on the line as well. So thank you very much, and over to you, Noreen.
Thank you, Richard. Thank you so much. So I'll just start with the session. I think this is a follow-up on what you had. You had a presentation last week about the salivary gland cytology Milan reporting system, and I think David gave a great presentation, and he gave discussed all the features in length. What I'm going to basically do is I'm going to discuss a few examples of what you've already had a bit of a literature and a few pictures shown. So I'm going to share the slides, and I would really like that if there is any sort of question or query during the slide whilst I'm showing feature, I would welcome all of you to sort of be more interactive and ask anything, and I'm happy to stop and explain further. So basically, as I said, this is your salivary gland cytology session, and I'm going to show you examples of various entities and the Milan categories. And I'm going to start with the benign entities and the most common ones. And this is Milan category 2, so we can just make up a history. This is your salivary gland plum, 18 millimeter, lobulated in a 56-year-old female. And can anybody confirm that they can see the slide? Yeah, thank you. Basically, I mean, the thing with the cytology is that for the histology sessions, you have your standard is H&E, and which is sort of uniform across the world. With cytology, the trick is that the trouble we usually face with the teaching, for teaching purposes as well, is that I think there is not standardization in terms of the preparations, and there are different type of preps and stains and different, and also different type of samples you get, and it can be very variable. And then that is why I think when we're doing a teaching session, you try to show your best stains and best preps, but I do understand that these can be quite variable from institute to institute and from region to region. The commonest preps you get for any FNA sample is your direct spreads. I'm sure you're all aware of that. And then you, depending on your centers, what do you do with the, once you've used up all the material from the needle on the spread, you can either use it to make your cytospends, or you can do a liquid-based cytology sort of preparation if you have that in your center. Or and in the end, everybody likes to make a cell block, and I do feel that cell blocks are quite useful, not just to do IHC, and I think for the molecular testing as well. So the first case we have, whenever I'll look at the, if we look at the inset on the right side below, we always, with the FNA sample, we always like to comment on the cellularity, except the lymph nodes, especially, and it gives you, it's a soft sign, it's a subtle sign, which tells you about whether you're dealing with, I'm not saying about a neoplasm, but as I said, it's a subtle sign. You can have a cellular lymphoid infiltrate, you can have an abscess which is cellular, but if you have a hypercellular sample with a lot of epithelial nests, it gives you an idea that you're probably dealing with a neoplasm. Now, going through the slide, please bear with me. They're very good scan images. However, they do take some time to sort of have sort of that pixelation removed. And you can see that they're large sheets, most of them, here as well. And they're quite, if I were to sort of describe in a very simplified manner, they're very basaloid looking large aggregates of cells. If I go closer to this sheet and I start looking at the edges, which is sort of thinner, you can see that there's a very nice rounded nuclei with fine chromatin. There's no there's no irregularity, and most of them are uniform. If you go to these cells which are more dispersed and are sort of simply scattered, you will see that there are these like nuclei which are pushed towards one side, and then you have this moderate amount of cytoplasm. And this is famously, this sort of morphological description is famously known or described as a plasma, and they resemble your plasma cells, don't they? And they you call, and because they resemble plasma cells, you call them plasmacytoid cells. So in the context when, and again, if you go through the entire sort of sample, and I mean, we will come to the main diagnostic or pathognomic feature, but if you go to all of these cells one by one, all of them are quite plasmacytoid, and again, the nuclear boundaries are quite round, they're regular, there's no atypia per se. Again, a small aggregate of basaloid epithelial cells. And if anybody wants to contribute to the chat box, in the context of cytokine pathology, something which resembles a plasmacytoid cell is which type of cell in cytokine pathology? Anybody wants to say? Myepithelial cells. Thank you so much, Vinod. This is really helpful. So yes, these, your plasmacytoid cells are your myepithelial cells. The other feature, which is so diagnostic, and I think you're all, if you've seen few cases, you all know what entity I'm discussing here, is this thing, this fragment, which has different names. And in different part of the world, people like to use different names. Some just say chondromyxoid fragments, some say fibrillated stromal fragments, and so you cannot see my screen. Is that the case with everybody else?
The screen is visible to me. Yeah, most people can see it.
Yeah. Arim, you might want to log in again, and that might help you.
Yeah,
Yeah.
so yeah, if you close
Yeah.
out and then rejoin, it should be fine.
Yeah, thank you. So, I mean, this fragment has different names, but I think the most useful name is, and the reason I'm saying this is myoepithelial derived stroma. And if you note that you have stroma, yes, and then within the stroma you have these entrapped spindle-shaped cells, and this is the best way to describe this fragment. And this is the most, I mean, we do try to describe the feature by the stromal color and its fibrillation. And its texture, and because it's fibrillated. But I think the most important diagnostic feature is the entrapment of the myepithelial cells within the stroma, and that's very useful. I'm stressing on that because we do get stromal fragments in other entities as well. And if you do not see, and if just based on the presence of this fragment of stroma and not seeing these entrapped myepithelial cells, does you would, or and you will, you will, because there are other entities as well which produce a lot of matrix and stroma, and it's a possibility that one can make a mistake. But it's quite useful and it's quite reassuring to see fragments like these. Again, you have nice fibrillations, you have the right color, and then you have the entrapped myepithelial cells. So it is quite important to see the entrapped myepithelial cells within the stroma. And I feel that when we teach that this is quite diagnostic, the one feature which we forget to mention is the entrapment of myepithelial cells. As I said, because you can see these, and I will show you other examples where you will have different, I mean, obviously benign entities, not a pleomorphic adenoma, which it is, can have stroma, but will not have the same entrapped myopithelial cells. So this is a Milan category 2, and this is a pleomorphic adenoma. If I were to go to this is the pap stain, which is a different stain. The Giemsa stains are usually, as I said, you make direct spreads. These are your adroit spreads, and your pap stains, you can either make a alcohol fixed spread, or you can put the needle, the material in the needle hub into your fixative and make a cytospin for this case. But again, because it's a different fixation, the cells are a lot smaller, and the same stroma, or the chondromyxoid stroma, is sort of less dense but has now a greenish reddish color, and same entrapped. And again, you can see that they have these processes. They are fibrillated, and then you have spindled uh, and then entrapped myopithelial cells. And outside the matrix, you have your plasmacytoid myopithelial cells. So this is your pleomorphic adenoma, and I think in terms of the Milan category, this is your Milan category 2. So this is pleomorphic adenoma. Going on to another entity. Uh, this is a 70-year-old male patient. I'll just wait for the slide to upload. And with a history of smoking. Again, if we look at the picture of the entire slide, it does look, even from the low power, it's quite a cellular slide. And we're just gonna probably one by one go through the component cell and the comment on the background. Now we can see that there are sheets. There are a lot of sheets. I mean, all over. If I were to go into this bit and I'll go closer to, so this is an epithelial sheet, again, very bland looking, uniform appearing cells. I'll go a bit closer. They are regular nuclei, fine chromatin. Um, and then there's, I would say, a mild to moderate amount of cytoplasm, quite thick. You cannot see the background of the slide through this cytoplasm. If you go to this larger fragment, they are even forming a papillary structure. There's a hint that there's a core going through it, um, but I will probably find something if I can. Again, if you can see, there is a fibrovascular going through. So we can see that there are these epithelial cells which have monolayered sheets, and some of them are forming papillary structures. Um, Same group, but much more sort of, because it's the thin part of the spread, so you can see the cytoplasm feature more clearly. Again, quite thick cytoplasm, nicely round nuclei, fine chromatin, and it's quite thick, glassy, I would say. And then we start concentrating on the background. If I sort of zoom out, you can see that it's a very dirty looking background with lymphocytes, histiocytes, and sort of cellular debris. So again, this is quite a typical appearance. Let's look at the same case at the pap stain. This is the background, and this is the description of the background, where I just, we just got this granular debris. You have histiocytes, and then you have the small lymphocytes, small medium-sized lymphocytes. You have your lymphoglandular bodies, and then these are the same epithelial sheets we saw in the on the Giemsa stain. And if I go closer, it's probably not showing the nuclear features very well. But if you want to concentrate on the cytoplasm, again, you have it has uniform appearance overall, and it has this thick amount of cytoplasm, which is very orangish and greenish in appearance, again because of the variable thickness. Another sheet, let's find another sheet. And this is actually better, sort of, you know, you can see the nuclei much better here. Again, quite uh, eosinophilic, thick cytoplasm. So these are basically your oncocytic epithelial cells, quite cellular, arranged in monolayer sheets. I did show you some papillary structures. The background has your typical granular debris, and then at the same time you have your histiocytes and lymphocytes. So this is a typical picture of if somebody wants to sort of, has anybody seen Wadden's tumor? Thank you, Punot. This is Milan category 2 again. So this is Wadden's tumor. Again, smoking history is quite typical. We've had few cases. It's just to give you sort of um, a tip where we had younger patients, and also it's also quite rare, but it's good to be aware of this thing. We have younger patients where we do sort of kind of put in a caveat where we don't get a history of smoking, or they're younger patient, or the clinical picture is not typical, because you can get oncocytic variant of mucoepidermoid carcinomas. And we did had one case where we all thought it looked warden like, but just because of the history and the lack of history of smoking, and the patient was a young female, we sort of raised a differential diagnosis. And in histology, it turned out to be a oncocytic or a warden-like mucoepidermoid carcinoma. There's no way of sort of picking those up unless, as I said, clinically it just didn't fit the picture. Or you can make a cell blog if you have a high index of clinical suspicion, and you can send those case for a mammography fusion. But I don't think that on cytology or even on histology, these are very tricky and they look very similar. You just need to be aware of the possibilities in the clinical, in the right clinical context. The other thing I would like to show, again, what we get. So talking about the backgrounds, if I go back, the one thing I would do like to mention that, again, these, although it's a simple diagnosis if you get all the features, but there's a lot of variation from case to case. And the variation is if you know your components, that you have your epithelial component and then you have background component, and if you just play with the proportions of these components in your head, then you can create these possible variations you get in real life, that sometimes you will just get the epithelial component in that instance, and you do not have the right background, you just have the oncocytic epithelial cells. So in that instance, I think you will put those cases in a Milan 4B category, in a sump category, because they can still be a Wadden tumor where the lymphoid component or the background has not been sampled, or they can be a oncocytoma, or they can be an oncocytic carcinoma or an oncocytic variant of mucoepidermoid carcinoma. In other instances, you may not get the epithelium and you just get the background, and you probably will just put this in a Milan 1 category, and you will ask them that, or you can always state, or you can put a comment saying that this is a very typical background, but you don't have the full-fledged diagnostic feature, they might need to repeat it. Also, coming back to the background and the point I was trying to make, the background again can also be, this is one typical sort of parents. The other is sometimes you could just get a lymphocytic background, which is very lymphoid rich. And the third sort of the spectrum within the spectrum of the background type is where you get a very colloid-like or proteinaceous-like background, where you have this mild cracking. So that's another pattern of the background you can get. So just remind, because I mentioned the lymphoid background. So this is another sort of an FNA from a parotid lymph node in a 36-year-old. And you can see that this is um, quite a cellular aspirate. And from wall to wall, I have basically lymphocytes, some of which are well preserved, and other ones have this crushing artifact because of slight prep. Um, and they're of various sizes. Um, If I go on a low power and coming, because I know this is a sample from parotid, I would look for epithelial structures. If I don't find them, this is again a common scenario where we get a sampling either from an intraparotid lymph node or from a lymphoid-rich cerebral gland neoplasm. Now, the lymphoid-rich cerebral gland neoplasm will stop. There is a long list of differential diagnoses within that, but in such instances, our standard report or the standard is usually that this is a lymphoid-rich sample. This could be either coming from an intraparotid lymph node, or this could be, a part of a lymphoid-rich neoplasm where the epithelial component has not been sampled, so they might need to repeat the FNA or do. It's best to have an excision rather than asking them to go back and do a core, because in the core you can again have the same sort of sampling issue. So, but now coming back to uh, the the differential diagnosis in in a uh, in a pattern where you have a lot of lymphocytes or entities which come under the umbrella of lymphoid rich neoplasm. So, do you do does anybody want to put in the chat box, and then what are the various entities we are aware of, which can have a lymphocytic rich background? One is Wadens, we've just discussed. The other one is a lymph adenoma, which is a benign entity. The same entity, when they have sebaceous differentiation, they're named as sebaceous lymph adenoma. So you have Wadens, you have lymph adenomas, you have sebaceous lymph adenoma. Amongst the inflammatory conditions, you can have chronic lymphadenitis, chronic cytidinitis. And then, yeah, thank you so much. Amongst the malignant entities, ethnic is the topmost differential, where you can have a very heavy lymphoid infiltrate, and sometimes it is so much that it really masks the epithelial nest. The other tumor, which is again quite commonly gets the lymphoid background, and it is the mucoepidermoid carcinoma. So again, it is important to be aware of all these entities, because then you can have the right differential diagnosis and the right approach towards whilst reporting the case. This is another case. This was quite interesting. This was a 46-year-old female with an parotid FNA. Is quite hypocellular, and you've got mostly blood in the background, some component cells, and I would say a slight increase in lymphocytes. So I would say probably coming from within the parotid gland, or from the lymph node within the parotid gland. This is again, your fibrin, but not a lot, in terms of the cellularity. But I've got something marked here. Let's have a look. So you can see that there's a collection of cells, and they have a lot of cytoplasm. You can't really see the cell boundaries, and they've got these. I'm not going to use but they're quite elongated nuclei, and there's sort of this whorled collection of these cells. I'll go to the other bits. Again, some sort of lymphocytes entrapped within the fibrin thrombi. There's a lot of crushing artifact. If I go to this mark again, well done, Sindhu, thank you so much. Again, there's a tiny collection of the same thing I showed, and somebody's already said in the chat box. So this is a granuloma. So again, you can see that there are these nice kidney-shaped nuclei, and then your slipper-shaped elongated nuclei, and they're sort of making this nice collection of histiocytes. And then where's the third one? Just to, again, sort of all your lymphoid infiltrate is entrapped within the fibrin thrombi. So you have your lymphocytes, and then you have a small collection here, few histiocytes here, and and then very tiny, small epithelium. So this is again a case where we had, although the FNA is from the parotid, but it's important to concentrate on the feature as well and not just think in the terms of the known diagnostic entities, because you can get any sort of pathology. So this was a granulomatous inflammation, and this was eventually, I think it was biopsied as well, and this was from within a lymph node in the parotid gland. So is everybody happy so far? So I've just gone through a few of the category 2, Milan 2 possible entities. Obviously, there would be other. You can have silidinitis. There can be acute silidinitis, but is there and then you have your rare entities where you can have sebaceous lymphadenomas. But does anybody has any questions so far? And I can move on to the next. No. So the next case is again a 45-year-old female, parotid lump around 20 millimeter, and I'm going to sort of describe this again. Coming back to if we start with our approach, it's quite similar. You can see from here and from here as well, a lot of nests. And then in terms of the type of cells or type of the nest, we can see that we have groups and nests of variable sizes. Some, and they're quite cohesive. And then they mostly are sort of round nuclei and then very scant cytoplasm. So they just, all of them are quite similar. There's not much in the way of polymorphism variation. Some are big, some are small, forming various architecture. I will come back to this bit where we can see a bit of a stroma as well. But in most of the spread, you have these similar looking, very blue cells with scant cytoplasm. Is it? I was wondering, how does everybody feel about what name they would want to give to these nests? If I give you A, B, and C, do you think these are oncocytic? Are these basaloid, or are these myoepithelial? It's just so that I get some sort of interaction. So they do look very blue. So yeah, basaloid. They're very basaloid because they don't have any cytoplasm, and because of that, the appearance is so. And because they're tightly packed and less cytoplasm, they all have this. So they are basaloid nests in the background, and then obviously we start to look for more information to sort of in your head. So I've already, because of cellularity, I think I'm dealing with the neoplasm. I have this uniform appearing, very cellular, lots of nests and groups, and they all look blue appearing. So we've decided they're basaloid nests. Now I will start to look for other information within the spread. And in the background, I start to look that, do I find any other cell? I don't. These are the same cells, which are sort of, uh, disrupted from the big nest. So whatever we have in the background is the same of what we've already seen within the groups. So we have the same cells. Now the only other thing which we found different was this. If we ignore the stroma at the moment, because I want to come back to it, what does everybody think? And we don't have anything else. We don't have any plasmacytoid cells. We don't have any atypia. What would be the best category to put this entity in? If some, So you have your Milan 2, which is benign. You have your Milan 3, which is atypia of uncertain significance. Then Milan 4, sorry, I want Milan, all your pleomorphic adenomas and everything is Milan 4A is benign. I'm so sorry. Milan 2 is inflammatory. Milan 3 is atypia of uncertain significance. And Milan 4A is your benign, which we've discussed. Pleomorphic adenoma, Warden's tumor, and then the granuloma goes into Milan 2. But 4A is your benign neoplasm, which is pleomorphic adenoma and Warden's tumor. But Milan 4B is again neoplasm. So they have divided the category 4 into A and B. So A is when you are definitely sure that this is benign and it's not going to be malignant, and there are very few entities. So 4A is usually when you have 100% sure and you found all the diagnostic feature within the spread that this is going to be benign and cannot be malignant. It's pleomorphic adenoma and Warden's tumor. Whenever you have any doubt, and by doubt I mean that you do not finding the diagnostic feature within the spread, and in your head you're aware that for this entity to be malignant, the criteria is invasion rather than finding any features on the slide, then you always put them in a category 4B, which is neoplasm of uncertain malignant potential. And under that umbrella, we mostly classify most of your salivary gland neoplasm in FNA, because a lot of in salivary gland pathology, a lot of malignancy is diagnosed based on invasion, based on infiltration of the parenchyma, which very similar to thyroid cytology or thyroid histology, I meant, can only be done on a completely excised specimen. So in an instance where you need to make a difference between a basal cell adenoma and basal cell adenocarcinoma, the criteria between the two is infiltration of the parenchyma, so which you cannot assess on an FNA sample. So in such instances, we have a category which is 4B, and if we just had this, you know, and we just have these uniform appearing basaloid nests, this could be anything. Again, the other important entity which shouldn't forget is adenoid cystic carcinoma. Again, that can also be tubular, can be cribriform, and can have solid nests. And therefore, this is a morphological spectrum within an FNA sample, which is quite common, but it has limitations because of various reasons. A, you cannot assess infiltration. B, um, this this sort of morphological spectrum can be seen in a various entity, and also it can be seen in a cellular pleomorphic adenoma. So this should be put in a category which is um, Milan 4B and should be labeled as basaloid neoplasm. But now coming back to the stroma, which I was skipping, and the point I was making earlier. And if I go on a low power, can we, if you look on a low power, again you have this bluish stroma, which I was showing you in the pleomorphic adenoma. But if you look at the pattern, it is sort of lining, it is present outside all these, I would say the groups or the ribbons of these cells, but it's present outside, it's sort of lining these cells. If you have a look, it's just present. Look at this finger-like projection of basaloid cells, and then it's present outside. Everywhere, I can outline this matrix outside the group. It's sort of laying around the group rather than being inside it. And also keep in mind that these are all basaloid epithelial cells. None of them are myepithelial cells. Oh, sorry. Again, if you notice, Obviously, this is folded upon each other, so that they become a bit 3D. But again, it's sort of the matrix is laid around these basaloid epithelial cells. It's not within them, and you do not see any entrapped myoepithelial cells. That's another. Again, this is a fibrovascular core. So this is a papillary architecture. But again, you can see that these are your basaloid epithelial cells, and you have matrix. And this is the point I was trying to sort of explain earlier, that if you go by this matrix and if you just sort of remember that, oh, you need a matrix for diagnosis of pleomorphic adenoma, you will make an error, and you will probably diagnose this as a pleomorphic adenoma. But this matrix has got a different sort of pattern, and it's not present. The way it's present is present around the cells. It does not have the entrapped myoepithelial cells within it, and there are in fact no myoepithelial cells within this that we can find. This is again some globule of the matrix, but again you cannot see any cells, any spindle-shaped myoepithelial cells within it. So this is a typical finding, which we usually see in a basal cell, I would say a basal cell adenoma / adenocarcinoma neoplasm, where they lay down the matrix. If you look at the histology of these samples, so they have their matrix laid down in a very scleroderma-like pattern. So this actually is a basaloid neoplasm with differential diagnosis of a basal cell adenoma versus adenocarcinoma, and this is a Milan 4B category. We cannot, as I said, cannot distinguish between an adenoma and adenocarcinoma, but and for that we need to look at the completely excised specimen. This was eventually a basal cell adenoma. Does that help? Anybody who wants to ask any question in the chat box? No. So we'll look at another case. On a low power, quite cellular again. What stands out, I think, if you have looked at your pictures, cytology book pictures, and if you go through this is the most beautiful sort of pictures, and everybody loves to sort of diagnose these. Again, I think I would caution that although that this is quite diagnostic, and it is a very book picture case, but still it's best to be safe in these cases, because we've seen many other entities with similar sort of morphological appearances. But even on a low power, we can see that in this sample, there's a lot of matrix. And this matrix is got this specific appearance. You see these globules of variable sizes, large and small. And if you go closer, next to the matrix and in the slide, there are a lot of basaloid epithelial cells with high nuclear cytoplasmic ratio, very sort of hypochromatic nuclei, scant cytoplasm. Let's go to an area which is a bit thin, so that we can look at some. Now, yeah, another sort of globules I'm concentrating because this is the best area to see. And again, they are lined by these basaloid epithelial cells in most parts, here as well. Sorry. Again, if you go closer, we know we can't see the cells separately, but this globule is, again, this matrix is lined by a lot of single layer of basaloid epithelial cell here as well. Can everybody see that? Yeah, so we can see that we have a, a lot of globular matrix, sorry, which is lined by basaloid epithelial cells, and then you have similar cells which are sort of dispersed in the slide. Um, so what would be the best category to put this case on? This is the pap smear of the same case. Again, all basaloid cells. Somehow there was less matrix. All the matrix sort of probably the sample is not evenly spread. So again, although we know that this is a sort of, and this is what we are taught, this is a typical appearance for an adenoid cystic carcinoma, and you see the sort of a very cookie cutter appearance. Please do note that there are no entrapped myopathial cells here within this matrix. Everything is sort of all these globules are lined by cells, but there's nothing entrapped within the matrix. But you can put them, and should ideally put them in as Milan 4B, basaloid neoplasm, where your differential diagnosis should be either a cellular pleomorphic adenoma, because I've seen cases and FNA samples of a cellular PA with a very similar globules. Um, you have features where you can distinguish them, because in that very sample I had plasmacytoid myopathial cells, but they were so prominent that if you put the slide in, you would just think that this is an adenoid cystic carcinoma if you just go by these globules. And this would look like a cribriform island on a histology section, the way it's present. Uh, or the other thing is that if you are pretty sure and you are comfortable with the nuclei that they're hyperchromatic and you angulate it, you can favor it. But I would advise to get a cell block and send it for MIPFISH, because as I said, this kind of globular matrix is just not unique to adenoid cystic. And if you are not aware of the subtleties between the subtle features, which can really help you sort of favor one over the other, one can err. And have had cases, but this was an adenoid cystic carcinoma. I think in this case, we probably got the cell block, and we were comfortable with histology and sent it for MIPFISH, and we called it Milan 6. But generally, if we don't have that, and if we have questionable features, if say per se I had my epithelial cells in the background, which is sort of unusual. Here in the background, I have similar cells, and I felt that they were more hyperchromatic, then we do tend to favor them. But it requires, I do feel, more experience, and you do have the option of putting them into a Milan 4B category and can probably give a differential diagnosis. So is everybody happy so far? Anybody wants to ask any question? The next case I'll show you is, so I know that the spread is sort of concentrated in this one little bit. This is a young patient, 20-year-old. I want to show you this case and then one after, and then probably we'll finish. It's a young patient, 20-year-old. If you just go by the cellularity of the sample on this area and just sort of forget because it's not being evenly spread, we would say again that's quite a cellular sample. And we can even up this power, we can see that these are mostly epithelial cells because these are cohesive sheets and they have some amount of cytoplasm. Now the next step is to sort of go closer to these nests and sort of look at the details of the cells and sort of spend time. They're quite loose sheets. This is the core, which I was not able to show you, but this is a fibrovascular core. going on to the loose sheets, probably here. Very round sort of polygonal cells. I can't see the boundaries very clearly, but if I were to sort of look at the cytoplasm, again, central base nuclei, round, regular, very monotonous, uniform appearing, no atypia. So we all sort of, I think you would agree with me that there's no atypia in this. But if you look at the cytoplasm, what does everybody think? Would everybody agree that they look very quite granular? They have this very basophilic granular cytoplasm, which reminds you of the serous SNR epithelial cells. But the next, so if we say that they look granular, and again, if I go closer, I will spend some more time. They look quite granular, and they have this basophilic appearance, and they remind you of your serous SNR epithelial cells. They're very bland looking, so one can assume that these are coming from your serous SNR epithelial cells. The origin of the cells is from the serous SNR cells. Again, here as well. So why isn't this a just sampling of your serous SNR epithelium, normal looking epithelium? And it's not. The reason I'm saying is it's all down to the architecture. So for these samples, the most important thing in this case, or in this, is to first to recognize the type of cell you're dealing with. And once you're sort of comfortable in your head that this is a cell which is originating from your serous SNR epithelium, then you need to look at the architecture. Your normal serous SNR, or the globules, or the normal your glands have a very, I don't have the picture right now, I'm sure Dave must have shown it to you. They have very grape-like structures, and they're quite cohesive. You don't get monolayer sheets, and you don't get certainly the papillary architecture like with these cores, you know, forming these cores and forming these loose sheets here as well. So ethnic cell carcinoma is on a cytology sample is a diagnosis of architecture. It is very, I mean, because your normal SNR epithelial cells in terms of the atypia and cytological features would look the same. It is basically the architecture. If I can quickly Google normal SNR epithelium just for the no. I don't. They're very grape-like structures. Probably if I share this. Oh. No. Sorry, I was trying to sort of Google and give you or find a normal SNR epithelium. But what I'm trying to is like that basically this having these loose sheets and any of these papillary structures is not a normal finding, and this is sort of quite useful in helping you decide that this is not a normal epithelium, because the normal SNR epithelium will be like all these papillary structures. This is an unusual architecture. This is quite abnormal, and the amount of the epithelium. You can have increased amount of normal epithelium in salidinosis. Beware of that. But I think the key to the diagnosis is basically the architecture, which is the oncocytes. Somebody asked, can they be oncocytes? The oncocytes will have a dense eosinophilic cytoplasm. Thank you for asking this question. They wouldn't have this granularity in the background, and you can see the background of the slide through it. So the cytoplasm for the oncocytes is usually very thick. Also, if I will probably do, I'm very happy to do another session. I can sort of do a comparison of SNX cell cytoplasm and a non-oncocytic cytoplasm in another session. But a non-oncocytic epithelium would have a very different cytoplasm. It will be much more denser. It will be much more glossier. If I were to go back to actually the Warden's case, that's this guy. Let's go to it. That's your oncocyte cytoplasm. It's quite thick. If you go closer, you will see some reddish granules, but they're very thick. And that's your SNX cell. They're very granular, basophilic, and that, So this is your Milan 6, and I think the key to the diagnosis again is basically getting the architecture or picking up on the architecture features rather than cytological features, because there's no difference and they are quite difficult at times. I think the other case which I wanted to show you for the same thing, I'm sorry I didn't have enough time to show Amico F. Again, can you see this is a very lymphoid-rich neoplasm? But somebody very nicely mentioned that SNX cell can be one of the differential diagnoses. And again, can you see the same cells I just showed you, which was lymphoid? There was no lymphoid infiltrate in just the case, but again, it can be very deceptive. And because they're so bland and their cytoplasm is so basophilic, they're hard to pick on. It's best to go sort of look at all the cells, look at the cytoplasmic feature, spend time on the cytoplasm, look at the nuclear features. But if I had the same sheet, but the cytoplasm would have been denser, this would have been a Warden's tumor. But this is not. This is an SNX cell carcinoma. So these subtleties of looking and spending time on the quality of the cytoplasm, the granularity, whether this is dense cytoplasmic, or it is fine granular basophilic cytoplasm, it's again important and sort of helps you to diagnose. But again, in this case, you can see that it's quite lymphoid rich. It has epithelialness. The architecture is not of a normal salivary gland, which is a very tight clusters, grape-like structures, which you usually get, and you do not tend to get loose, cohesive, or papillary-like structures in a normal salivary gland. Is that okay? I'm sorry. I think we've.
You okay? You okay, Noreen?
Yeah. Is it?
Yeah.
Yeah. Sorry. Should I finish? I think it's hours up.
Yeah, that's fine. I mean, are there any more? Thank you very much for that really, a really good talk. You covered it. I think I know from myself, from experience, how challenging it is to be shown cases live.
Yeah.
So I'm very grateful for that, because I think it's really good to go over, particularly these cytology cases, showing the whole section and focusing on the areas. I think the images came through really, really clearly.
Yeah.
I was particularly, I think the description of the acidic cell tumour at the end was really good. I certainly learned a lot. Are there any questions? And we'll certainly have you back for another session, as you've offered. Not in the immediate future, because we have lots of people lined up, but we'd be delighted to have you back. Are there any questions from the audience, please, before we finish? I know we are up to the hour now.
Yeah.
We've got some votes of thanks from Cindy
Yeah, no.
and Ahmed and Vinod. Anyone else want to give their thanks to Noreen? If people want to just quickly, anyone put in the chat before we finish their locations out of interest, so we can see how far Noreen's teaching has gone. Thank you, Chrissy Sir.
Oh, Manchester.
Someone from Manchester. Okay, so we've got people from all over. Must be maybe one of the trainees.
Yeah. Yeah.
That's great. So, India, Zambia, it's an excellent geographic spread. So, thank you very much, Noreen, for
Thank you.
your time and also your patience with the technology. And you've identified a very key thing for us, which is to not use Edge, but to use Chrome.
No, I'm happy to take questions. Obviously, it is. I found it challenging because I love to have some sort of interaction and see if everybody's understanding what I'm saying. So.
Yeah, are you able to just quickly put your email in the chat then, in case anyone wants to get in touch with you? Just
about any feature they want to ask further, because I feel that everybody has sort of different difficulties when they are looking at cytology, different challenges.
Well, thank you very much. I think I'll let people go. Next week it's back to HemePath, so it'll be myself.
Thank you.
I'll either be showing kind of recent cases, trophonic cases, or probably do a mixture of that and some lymphoma teaching using whole slide images. Thank you very much for your attention, everyone, and your patience with our technical difficulties at the start. Thank you very much to Noreen in particular for an excellent session and for swapping it to this week. And thank you to Ava for her excellent help. Let me just check the timetable for next week. Make sure I've got everything correct. So next week it will be, for those of you who are still on the line. So I'm just trying to look through the line here. Yeah, so next week it's actually going to be Sarah Coupland, not myself. So Sarah Coupland from University of Liverpool, a very prominent ophthalmic pathologist who's actually even got a Wikipedia page of her own. But the teaching next week will be on Thursday the 18th, because Sarah will only have just come back from travel. It'll be the same time in whichever territory you're in, but it'll be on the Thursday at 1 p.m. UK time, and whichever time it is normally in your territory, and not on the Wednesday. So that's just for next week, moving to Thursday. Ophthalmic tumours. So please, as many of you attend as possible. Sarah's an excellent speaker, an international speaker, so we're very lucky to have her teach on this program. So Ava, unless I've forgotten anything else to say, we can close the session. Is that okay?
Yes, sounds good. Thank you so much.
Okay, thank you.